G'day everyone, it's Greg Ryan here. Welcome to episode 17 of Rare and Resilient 1 in 5,000 podcast. And today we are joined by Dr. Bruno Martinez Leo from the Moctezuma Children's Hospital in Mexico City, who is a Pediatric Colorectal Surgeon. Welcome, Doctor.
Thank you very much, Greg. Thank you very much for having me here.
Oh, it's a pleasure. You're the first person from South America we've had on the podcast, so it's great to
let's celebrate.
Yes, it's great to be able to capture all the different global countries. So if you want to just give us a bit of a background of your history.
Yeah, of course. I trained at Mexico City at Moctezuma Children's Hospital. It's a very busy children's hospital with treating about 3,000 patients per year in general pediatric surgery. It was a very busy training. And then I had the opportunity to visit Dr. Alberto Pena at Cincinnati Children's. And then I had the golden opportunity to go back and make a fellowship there with him 2014, 2015. And it changed my life. That's where I treat patients with colorectal patients. I came back to Mexico City and I returned to that hospital where I trained. And I have the fortune to operate on them and follow them up as much as possible. And the real nice thing of that hospital is we treat the poorest kids in this city for Mexico City. We treat the only patients with no social security or no insurance. So we try to do any effort to make their lives better as better as possible, as best as possible.
That's wonderful. And I'd imagine that the parents and the families, they wouldn't have a lot of support as far as getting the stoma supplies and all that. How do the parents deal with that after you've had the surgeries? Do they have access to all the proper supplies?
No, they don't. Actually, there's no government treatment. I mean, the government doesn't give them the supplies and all the things they have. We have a wonderful stoma nurse there that makes miracles with whichever they have to do, but they don't have the amount they really need. So most of them take out of their pockets to pay for the stomach bags and the powders and all the things they actually need for that. And most of them are just as your foundation. They are very resilient, and they find a way to make it better for their kids.
That's wonderful that you've got such a great stoma nurse and the people around you, because that makes it's so important, isn't it, for the ongoing care?
Yeah, it makes a lot of difference, quite a difference. And I joke with my patients and I say, okay, that's the next room when I treat them and they start to have real problems with stomach. I said, well, that's the nurse's office. You have to go there. And then she works out a miracle and they get better. So you need a very dedicated nurse for that. So I am very grateful to her because she is also very professional and takes very good care of them.
Well, that's wonderful. And how many ARM patients would you normally treat like in a year?
Like in a year, I'm operating about 100 patients for anorectal repair, and maybe a little less number for stomach closure and diagnostics and all the things that are done in the operating room. We have an active database of 300 patients that we have treated, and we have followed them up for the last 6 to 7 years. And that's what keeps us very busy. It might sound like a small number, but they are very important for us.
Yeah. And do you treat adolescents as well?
Yeah, we treat adolescents as well. In Mexico, some hospitals by law makes you send the patients to the adult healthcare when they are 16 years old or older. In some other places, it's after 18 years old. That's when they reach their adulthood here in Mexico. But we trickle system a little bit, and we still see them when they need.
And do you have a transitional program to an adult hospital, a specific adult colorectal surgeon?
No, we don't. we are starting to talk to them, but it's been a very difficult way to get to them because they don't know about that, the congenital malformations, as you of course know. But it's very difficult to find an interested colorectal surgeon in anorectal malformation for that. So we are still looking. We have friends that we can talk to them, and sometimes they talk to us. But as a program, as we would like to settle, we don't have, as we don't have a special program for fertility, for example, right? Girls with cloaca or with problems in vaginal septum, things like that, or duplicate uterus. We don't have a transitional program. They have a place to get there, right? There are specialized places where they can get to, but the transition, we have a long way to walk to get there.
Unfortunately, it's one of the great difficulties globally with ARM patients, isn't it? And unfortunately, the adult colorectal surgeons just treat our condition as a pediatric problem. There's so many that just won't open their eyes to what needs to be done, isn't it?
Yeah, pretty much, because most of the colorectal pathologies, which I have tried to learn a lot from them, from the adult literature and the papers, most of them are acquired, right? And most of them deal with colorectal cancer. So they have a lot of attention into that. And congenital anomalies, they don't seem to have a very big volume on that. And what I've learned over the years is that some surgeons tend to say to the parents and the babies, then older children, that they are going to behave like that. A patient with anorectal malformation, it's like it is, right? And sometimes they think that it's normal. They have a diaper when they have 9, 10 years old, and because they think that it's normal, but it is not. So my wild thought about that, my wild guess is that there's a lot of adult patients surviving day to day with a congenital malformation, of course, and fecal incontinence and urinary incontinence, then they think that it's normal, and they don't really seek for help, right? They
Yes.
find ways to cover that up and try to be functional in society. Some of the patients have come to me because they listened to a talk that somebody uploaded in YouTube, and I said that fecal incontinence is not normal. Nobody has to have fecal incontinence. So some patients find that talk and get to me, but I think there is a very huge paradigm about that, right? Because it's congenital, you have to live with that, and there's no way to solve it. And that's not the truth. You know it, and there's a lot of things we can do for those patients.
Yeah. Have you seen any adult patients yourself, or are you allowed to see adult patients at your hospital?
Not at the hospital. The older patient I have following up, she's 22 years old, and she had an unrepaired cloaca until we met when she was 14. And it's a very striking case. I have her with me all the time because she came in asking for a vagina. They did the colorectal pull through, but they didn't treat the urogenital sinus. And she went to me when she was like 14 years old, something like that. And she said, I want a vagina. I want to have a vagina. And we did the follow-up and the workup and everything she needed. And we found out that she didn't have the surgery for the urogenital sinus. She's now 22 years old. That's the oldest patient I have. I have seen some other older patients, like 35 years old, 30 years old, that they have their malformation repaired, but they are living a normal life. Sometimes they ask just out of curiosity if they need something else, but it's not a common thing. I can count them with my hand. Very few patients go and look for help, or know that they can be treated, right?
Yeah, it's just, it's unfortunately, it's something that we just need to try and get some awareness of out there in the adult colorectal community. But you're right, that I know myself, the adults just, once they leave the pediatric care, they think, well, this is my lot and I've just got to deal with it the best I can.
Yeah.
What influence did Dr. Pena have on you when you were at Cincinnati?
Oh my, it's a very long answer. I'm gonna say a very brief part of it. He is the most important mentor I have, no doubt about it, in every aspect. I grew up without a father, and he fulfilled some of that lacks that I have.
Oh, really?
And on the other hand, I admire her deeply. I admire him deeply as a surgeon, and a very a person with a very high moral authority on anorectal malformations. He has a very deep understanding of anorectal malformations. Of course, everybody knows that, but he also has a deep understanding of his patients. And now with Andrea Bishop taking care of them as well, and Luis de la Torre, they have a very deep understanding of the personalities and the needs of their patients. If you read Dr. Pena's book, the first book he published, Atlas of Anorectal Malformations, and then you read the book he published in 2015, which my commercial here is I helped with that book, and the final edition of that I helped.
I've got an autographed copy of it. It's in pride of place in my bookcase.
I have two. I have two of them. But you can see an evolution of what he learned, and everything he has shared over these 40 plus years of life that he has devoted to colorectal surgery. And that is something I most admire of him, because he's always sharing about that. And he has a very humble position on that. He says, we have operated on 600 and plus cloacas, and he humbly says every presentation, and we are still learning, right? He always says, we don't stop learning. I think that's the most important thing, right? And what I said to my residents, what I most learned, where I learned the most during that year was not actually in the EOR. It was having lunch with him. I had lunch with him several times. I learned a lot about that. We discussed cases, we discussed things in life, surgical technique, a lot of things. So I'm very grateful for him, because the most he gave me was time and knowledge, more than actually secrets of colorectal surgery or things like that. And the example, he led by example about that. So that's the most important thing.
Oh, that's wonderful. And do you have many colleagues in your hospital that do anorectal malformations, or you look after most of the patients?
I am the one that makes the colorectal surgery for all the patients.
Okay. And
my older teachers are there, and they took care of anorectal malformations before I came in, and they are still there. We share information and cases, but I am the only one.
Do you have many cases where you have to do redos?
Actually, no. After it's a funny story, because my previous chief of surgery, he was with Dr. Pena, 1989, something like that, and he took everything he knew. He took to Moctezuma Children's, and their pupils, who are my colleagues now, they learn very well, right? So it's not as common as you may think, but we have a very closed community of patients. As we are not a very big hospital, we are not a National Institute of Health, we don't get a lot of referrals. We get referrals from inside the city. So that's why I don't have plenty of redos. Most of them, thankfully, are just primary surgeries.
One other thing which is really close to my heart is, is there a patient organization in Mexico for families?
No, there is no organization for families. There is a couple of groups in Facebook that they are growing very fast, but they include a lot of people with ostomies, adults, colostomies, ileostomies for any cause, and some of them are babies, some of them are patients with anorectal malformations, but a specific group for parents treating like that as an organization, there is not. I am sure there are a lot of groups of parents that are getting together in an informal way, right?
Yes.
And some of them reach out to me or to other of my colleagues that do colorectal surgery at other hospitals, but not as organized as we would like or they would need to happen.
Oh, okay. Well, we'll see if we can do something about that, hey?
Yeah, that it's very much necessary, right? There are two non-profit organizations. One is the one I collaborate with. It's called Momentum Foundation for Congenital Colorectal Diseases.
Yes, I've heard of them. Yes, I follow them on Facebook.
Yeah, we follow each other. Yes, and their aim is to help treat every person with a congenital colorectal disease. And there is another organization, quite older than ours, maybe it's 4 or 5 years older, that is called Colon Feliz, Happy Colon. And they also give help to patients and parents in need of economical distress and things like that, giving information for patients that are in need of that stuff. So those are the only two organizations, non-profit organizations I know of that they are devoted to that.
One of the other reasons I got you on, Doctor, was to talk about the recent publication in Lancet of the global PaedSurg cohort study, which included 3,849 patients from 264 hospitals and 74 countries across the world, conducted between October 2018 and April 2019, which was published on the Lancet on July 13, 2021. And it includes 7 congenital conditions, including anorectal malformation. So can you just give us a background of that study and the results that came out, especially for the low-income countries?
Yeah, certainly. It's a very interesting story led by Naomi Wright. She did a humongous work. It's been like 4 years of working with her. I met her at Washington, D.C., 2016 in person, because we used to be Twitter pals before that. And we talked about it, and we started this endeavor. So a lot of people contributed to this information. And as you said, the numbers are just impressive, right? The most important conclusion in this study for every condition studied is the unacceptable differences in care among different countries, right? In the case of anorectal malformations, takes a lot of importance because the bigger group of congenital diseases in these other conditions is anorectal malformations, around 25% of them. And it's very interesting because as long as for the mortality rate in anorectal malformations in particular, it's very low for very high income countries, but it's very high for middle income countries. In anorectal malformations, only 7% of them have their problem solved, right, before they were discharged. And most of them, as the bigger series of patients, have the same type of malformations, right? Perineal fistula is the most important, with 33% of the patients, followed by vestibular fistula, and then cloacas are only 5% of them. The most important thing about it in terms of differentiating from one country to another is the appalling rate of mortality related to it. Not specific to the malformations, but to the conditions in which the patients arrive to the treating center. That's the most important aspect we found for all of the studies, for all the malformations studied here. And it's the same for anorectal malformations. The anorectal malformation per se did not represent a problem for mortality, but the presence of sepsis when they get in, right? And the need for total parenteral nutrition, and it was needed but not available. Those are the most important things when it came to mortality in every condition studied.
I note that the results were that for high-income countries, the mortality rate for ARM patients were 1.7%, middle-income countries 12.1%, and for low-income countries, it was 20% mortality rate, which is incredible, isn't it, really, the difference?
Yes, it is. It's unacceptable as our most important conclusions. It's just an unacceptable difference in different countries. And the most important thing is that you don't need a lot of technology to treat anorectal malformations, right? If you say I need a very specific robot that costs $10 million, well, you will say, okay, that's a very important thing to prove among patients, among countries without the money to get it, but it is not. And maybe some of that, we have to dig into that, but some of them might be the result of a late diagnosis in anorectal malformations, specifically the low malformations, right? Just as in the book you edited, a lot of patients were sent home with a perineal fistula, right? And they just knew something was not going okay because they have severe constipation, right? And maybe this is one factor that might affect those patients, the time between the diagnosis and the time they actually got their problem solved. Only 7% had the problem solved. That's very important. And 54% of all the patients among all different countries, they needed something to be done after they were discharged. And that talks about, we know that every patient has to be followed up for several years. But the patients that have to be discharged, their problem was not solved. That talks about that there's something we are missing there, or in the end, a lot of them needed a colostomy, like the number says, and they actually are going to need more care after they were more than 1 month of age.
I have particular interest in that because of what we do with our Help for Ghana project, where we're sending unused stoma and urostomy supplies to Ghana to help these children, because invariably most of the children, when they have their colostomy surgery, the stoma is just uncovered and it just stays there. They actually don't get to the pull-through stage. So the children are walking around with uncovered stomas, and for a lot of times forever, because they just haven't got the means to get the surgeries done.
Yes, of course, it's a problem. When I got back from the United States, one of my goals was to reduce the time between the diagnosis and the colostomy closure. And when I got in right in the hospital, it took about 2.5 years for the patient to get their colostomy reversed.
Really?
And yes, and we are now, well, before the pandemics, we were doing it 9 months after the patient was born, and then the colostomy was closed around 9 months old. That was the goal in early 2020, and now everything has been delayed, but it can be done. Actually, most of the credit to that goes to the stoma nurse and a person dedicated to those patients specifically.
That's incredible that you've reduced it from 2.5 years down to 9 months, because you can see parents from all over the globe they're getting their stomas closed within sort of like 5-6 months. The closures now within 5-6 months after they were born, aren't they?
Yeah. Yes, of course, and there is a lot of burden about not only financial. That's the most visible burden they suffer, the parents, but the emotional stress, and they have questions like when is this going to be solved, and they know that their babies are not like the other babies, right? They are pooping through the abdomen.
Yes.
And they actually don't express that, but you can see that they have those worries, and that I am certain that keeps them awake at night, and they look for solutions, economically, and ways to solve the problem. And when they don't have stomach bags, some of them use diapers, and just as you explained, and that is something that we must work to improve the time before the time between the diagnosis and the colostomy reversal when they have a colostomy, right?
Yes.
The other thing we have worked a lot is in operating low defects without a colostomy. We have worked a lot in several patients that can do that, and we have good results. And even though they have to stay in the hospital for 7 to 10 days, and they have to use TPN, well, they only undergo one surgery. Instead of opening a colostomy, then the anorectoplasty, and then a colostomy reversal. And that, in terms of money and the stress and psychological effects on parents and patients are an improvement to their care.
Speaking of the psychological sort of part of in the study, was that taken into account at all?
In the study, in this study with the global pediatric surgery, no, we did not.
No,
it's a very important aspect, but no, we did not.
What do you think was the most important thing to come out of the study? And I would encourage all listeners to refer to the study because it goes into incredible detail, and like there's 16 pages of it on the Lancet, and it's available to anyone to access. But I would really encourage it because it's for ARM community, especially for clinicians and for families. It's just such important reading, isn't it?
Yeah. It's my all the statisticians that made all this analysis have all my respects, right? That's the most solid part of this study because we have a lot of patients. We have almost 4,000 patients, and almost 1,000 of those patients have anorectal malformation. So we have to study further these patients because this is a subset of data that is going to give us even more information to help them better. And the thing is, everything we knew about a lot of patients with anorectal malformations, such as associated anomalies, we have this now in raw numbers, right? Like genitourinary malformations, cardiac malformations, how are they treated around the world? And the most important thing is a lot of patients do have these malformations and they can go to a place to get care about it. And the study, the most important information is the most important aspect of this study into patients or the REM communities, that we have now more solid data. We have a lot of series, right? We can say that Dr. Pena has the largest series in the world when it comes to a lot of patients came together. But this is a very heterogeneous subset of patients, right? We have high income countries, we have low and middle income countries that they are showing a lot of data about anorectal malformations. The main difference is mortality, right? High income country will have a very low mortality, while the other countries will not. But we have a very homogeneous clinical information in this study that Naomi and I are going to work into making a better analysis and all the subsets of indicators that how does this really affect productivity and how does this really affect what is called catastrophic expenditure, right? And how does it affect these families into terms of how much they spend in, as you said, stomach bags and going back and forth from hospitals, and how long is the hospital from their homes. That is a very important aspect that the study revealed. No, the distance between where the patient was born and where the patient was actually treated sometimes went like 50 kilometers. You might say, well, I take a car and I drive half an hour and I'm there. But we know very low income countries, they don't have even roads sometimes to get there.
Yeah, I've got a really good example of that. We funded some surgery for a little boy, in Ghana, and they lived in a village. For 15 kilometers, there was no road. So to get them into the hospital, they had to send out motorbikes to put them, the mother and the child on the motorbike for 15 kilometers, then get them into a car and then drive 3 hours to the hospital. It's just, you think of that and it's just incredible. And the other thing I'd imagine too is with the low income countries, tragically, the kids wouldn't even get to the hospitals to get the treatment, would they? They were, depending where they're born, they just might not have the skills to be able to treat the patient when they're born.
Yeah, of course. And they receive a very late treatment. If they have a perineal fistula, they will survive because we've seen that, right?
Yep.
We've seen boys with 2 years old. A couple of months ago, I operated on a 2-year-old boy that he had a perineal fistula. He's okay. He didn't die. But patients with they don't have any opening, no anal opening at all, they will probably die from hollow viscous perforation, and it will happen in 3 or 4 days. And the most important thing that I with that distance from one place to another, as you said, they have to get into motorbike. You might find very, very distressing that this kind of things happen actually within Mexico City, right?
Really?
People that has to travel 3 hours to get to the hospital, right? Because they still live in the city, but the access to that hospital is just too far away, or they are born in the northern part of the city, and they have to drive across the city. That in a car would take you half an hour, 45 minutes, but they have to use public transportation, and it might take them sometimes 3 hours. So in the state of an emergency, they are actually in danger, even if they live within the city.
Yes.
It's appalling.
Yeah, like, and that's why this study is so groundbreaking, because you know that there's the main centers in America, like Nationwide and Cincinnati and Denver, that have done their own studies on their own cohort, but to have this worldwide, because I know we had surgeons from Australia participate, which was wonderful as well. It's just an incredible thing. And I was fortunate enough to meet Naomi Wright a couple of years ago at a conference in England, and she's such a wonderful person. And what she's done, like especially for the sub-Sahara African countries, it's amazing, really.
Yeah. It's a very big enterprise she has gotten into, and it's deeply admirable, because it's a tremendous effort to coordinate all those surgeons, all that information, all that people. I have the privilege of being on the organizing committee, and it is a tremendous amount of work. And the information, the raw information of this study is just going to be helpful for years and years and years to come.
Oh yeah, I've got no doubt about that. And it's just, and it'll help clinicians all across the world who really never ever get to see an anorectal malformation patient as well.
Yeah, might happen. Yes, I actually have a couple of maybe 5 years now that I ask to a specific group of medical students. They go over the years they go to the hospital, and I ask them 5 questions, and only around 4% of them have seen a patient with anorectal malformations. We are talking about right now there must be 150 now doctors, right?
Yes.
They finished their training in general medicine, and only 5% saw a patient with anorectal malformation. I ask them that before they start their rotation with me, of course, because when they get to me, we see patients with anorectal malformations. But it's something to worry about, because one of the problems that they go undiagnosed is that they haven't ever seen a patient with an imperforated anus. Nobody taught them how to explore them. And what I usually tell them is, if you see that anus, it's funny looking, it's weird, something doesn't add up, send it to a colorectal surgeon, ideally, or send it to a pediatric surgeon. Then they can take a look and say, yeah, something's wrong with the anus. Let's make further studies, right? I think the most important thing about the study, just to conclude that, is the unacceptable differences in mortality for every cause, right? We have a lot of patients with anorectal malformations, right?
991 in the study.
Yes, almost 25%.
And so that's the most of any group that was in the study, actually.
Yes, it is. So maybe we have to update our statistical data on how many patients are around the world living with an anorectal malformation. That's the most important conclusion for me, in terms of what would you tell people about this study that they have to take an idea about it, and that there is unacceptable differences in mortality rates just because the access of care they have, right? It's not really about if the surgeon did well or not with the patient. The most important thing is they got late to the hospital, and they were sick when they got into the hospital. That's the most important aspect, right? And there are some other indicators about it, but that's the most important conclusion. And another thing I want to add is to congratulate you on this also very important effort on increasing awareness of anorectal malformations. It takes a lot of courage. It takes a lot of guts to stand up and say I had it. And I usually tell to everyone, if you get an operation of the heart, you open your chest and you say, hey, this is my surgery, right? But nobody's gonna say, hey, I had an operation in the anus 50 years ago. Look how it goes. And it takes a lot of courage. So I want to congratulate you. I'm very happy to meet you and to be Twitter pals and Instagram pals, because it helps people that they are not alone, right? There's something that there's someone that cares about them in terms of personal feelings. And there's a lot of doctors that we are pushing to improve care everywhere in colorectal surgery. Maybe Moctezuma Children's is a very small hospital, but I can assure you we do everything in our power to make those patients' lives better than they are when they get to us.
Well, I appreciate the kind words, but I'm only just maybe a little small part of it, and I just try to, if I can help people not feel alone. But clinicians like yourself, you're the most important people, because you're the one who treats the patients and gives them the quality of life that hopefully that they can achieve. So I have to thank you more than you thank me, I can tell you.
I like to think we're like a team, something like that. Everyone does their part, and everything works out for the patient. So thank you again. I want to be sure of saying that. And I don't think I'm going to say it enough. It's very important, the work you're doing.
No, I appreciate it, Doctor. But as I said, our community is so wonderful, and the families and the clinicians, and they've embraced what we've been trying to do, especially like with the foundation, with the, what we've done with the Help for Ghana and trying to help kids and just refer other families to each other, and just to make them, and for the kids not to feel alone. That's the most important thing. So, Doctor, I can't thank you enough for the information you provided, especially about the global PaedSurg study. Was really valuable, and I'm sure we'll have listeners go refer to the study and get some more information. And what you're doing for your patients in Mexico City is, it's wonderful. They've got a surgeon with your background and your care for the patients to look after them and their families.
Certainly. I'm happy to say I am not alone. There are some other places in Mexico City that treat patients as well. We're a small community, but we're striving to do better and work together as well. Something that is not always possible, but we are trying, and I think we're getting there.
Oh, that's great. Right. All right, Doctor. I'll talk to you again soon.
Certainly, anytime you want. It was a pleasure talking to you here, and I hope my English was fully understandable. And let me know if I can be with you any other time. Happy to talk about colorectal diseases. And thanks again.
I'd love to be able to do a Spanish one, but your English is a lot better than my Spanish, I can tell you.
well, we can make some Spanglish, right?
Yeah, we'll work it out. All right, sir. Thank you very much. Bye-bye.
Take care, Greg.
Bye.